So I'm going to follow up and ask you about maintenance therapy. We have numerous different clinical trials, a decade of experience or more of using rituximab and now other CD20 antibodies as maintenance therapy. Initially, there was, I think, a lot of enthusiasm for maintenance therapy in the notion that perhaps a progression-free survival advantage would ultimately translate into an overall survival advantage. That's been a little bit more elusive than we originally thought. We now have multiple choices of drugs that we can use or anti-CD20 antibodies that can be used as maintenance therapy. So what do you tell your patients?
Yeah, it's an important question, I think, and I think you're right that there were a lot of early adopters of maintenance therapy, and then there was some peeling back on that. The PRIMA data were really strong. So the PRIMA trial was the trial that added 2 years of rituximab maintenance after 2 years of our chemotherapy, and it demonstrated a significant progression-free survival benefit without an overall survival benefit. And so people that wanted to be in a remission for longer were more likely to say, please give me the maintenance, as opposed to other people who maybe wanted to spend a little bit less time in the doctor's office, and they said, well, I'll deal with it, and probably another 5 years from now we'll talk again. And I think that, like Younes, we were at Cornell, and myself personally was maybe a little bit less inclined to give maintenance, saying, we'll deal with it when we have to deal with it. The PRIMA data now with 10 years of follow-up remains strong, right? So at 10 years, 51% of patients that got maintenance are still free from progression. So that's a clinical trial. We don't know what that would be like in the real world setting, and that's an important point. But it's basically an extension of the same conversation. It's still the same conversation. It improves progression-free survival without a difference in overall survival. So we'll have the conversation, and now we have more data to add to it.
Greg, do you agree? And what do you do for your patients? And now I think there's even some discussion about how long you should do maintenance therapy, right? There's data from the STILL group looking at 2 versus 4 years of therapy. What are you telling your patients?
Yeah, the STILL study showed that there's advantage of prolonged maintenance rituximab for 4 years versus 2 years in terms of progression-free survival. Now, most of those differences, as you pointed out, are in progression-free survival. So there's a very individualized decision in discussion with the patients which option one would take. And in general, I find that people are falling into 2 categories. There are patients who basically say, I'm done with the chemotherapy, I completed it, I'm happy to follow, but I would not necessarily would like to pursue additional maintenance. And there are folks who really feel very strongly about doing everything possible to keep the tumor under control. And then we discuss the data, and those folks typically would select maintenance therapy. The duration will, after this year ASH, will be another discussion which we'll have, and potential additional benefit of adding 2 years for Rituxan to maintenance.
Can I add one more thing? So what's confusing, I think, in the field, that there's another trial that was published recently in JCO, another 10-year follow-up from the Italian group where they used our chemo versus chemo. When the 10-year follow-up, R-CHOP with no maintenance gave also about 10-year progression-free survival. So, I mean, there is data to support either or. If you give it, it's fine. If you don't give it, it's not a malpractice. And I think that's a discussion for all of us with the patients. And some of them would want to get Rituxan maintenance or obinutuzumab maintenance, and that's perfectly fine. But if you don't give it, I think it's also perfectly fine.
How does that, all this realization about the color your interpretation of the gallium trial, right, where there was maintenance with obinutuzumab? I find it difficult because I felt like for 10 years I was telling my patients that I think it's probably good to have maintenance therapy. Now I'm less sure of that, but then trying to interpret the gallium trial with obinutuzumab maintenance, and that certainly was superior.
Right. I mean, it's certainly in a disease where the median survival now exceeds 18 years, and safety and toxicity becomes an issue. So you need to make sure that the patients who are treated, they would get also safe treatment. We're not exposing them to toxic treatment that may impact subsequent therapies. So this needs to be factored in. In a perfectly healthy person, I think it's no problem treating patients with maintenance. Honestly, most of us were shocked when we saw the data from gallium, because all of us said, I never seen this in my patients, but data is data. So I'm sure that some patients may not tolerate this kind of treatment, but it's rare in clinical practice, in some, at least in some of our experiences.
Loretta, how about you? Any difference in your opinion on the subject?
Yeah, I think the problem with the gallium study is it was designed to tell us which CD20 antibody was superior, but it's a very large prospective study of follicular lymphoma patients with over 1,000 patients. So now we're learning more in terms of what is the toxicity profile associated with chemo and CD20 antibody, and we, for the first time, saw some prospective data looking at CD20 maintenance following bendamustine. We do have the still data at this ASH. In your BRIGHT study, there are about half patients that did receive maintenance, but it wasn't prospectively built in. So I think what we've learned from this is there are some toxicities that you have to be mindful of after patients complete their chemotherapy. And we're seeing some subgroup analysis come out of the gallium data where it looks like particularly some of the CD8 effector cells may be impacted after they stop the bendamustine. So I think now this raises more complexity, and the discussion you have with patients is just because you're in this maintenance phase and we're less worried about toxicity associated with chemotherapy, there still are toxicities that you need to be mindful of, including infection. The other issue is second cancers. Now, we know patients with follicular lymphoma are more prone to second cancers, probably due to failure of immune surveillance. But when you continue these therapies more prolonged, are you also enhancing that risk? We don't know the answer.
I think that's a great, Greg made the point earlier as well from the Mayo Clinic, the Matt Maurer data looking at EFS 12, where it's clear that a significant proportion of patients have a survival that's equivalent to the population without lymphoma, and their life experience is not one of excess mortality, but one of excess morbidity. And when we're managing people with follicular lymphoma, as Loretta says, one of the keys is to minimize morbidity because chances are they're going to do well regardless of the choices we make.